Hello everyone, welcome to our topic for today is acute pericarditis. So how does the patient present? Usually chest pain that worsen with breathing. So what's our differential? Could be myocardial infarction, could be pulmonary embolism, could be pneumonia, could be GERD, could be musculoskeletal pain. So how do we tackle this case? We usually physical exam, history will tell us acute myocardial infarction. Usually there's a vomiting, nausea, autonomic activity, radiating to the left, elephant sitting on your chest. Pulmonary embolism, usually sudden, there's hypoxia. Pneumonia, there's cough, productive cough. GERD, there's burning. Musculoskeletal is on physical exam worse by touching, okay? So these are the things. After that, we confirm diagnosis by history, physical exam, and EKG finding. Okay, you evaluate for cardiac tamponade with echocardiogram. You order that just in case there is a pericardial tamponade, and you order pericardiosynthesis if there is large effusion or if there is pericardial tamponade. What are the admission criteria for CCS? You gotta know the admission criteria for each and every single case. It's very important. So the admission criteria is that you have fever more than 100, cardiac tamponade, failure to respond to non-steroidal anti-inflammatory drug within 1 week, if there's immunosuppression, if there is anticoagulated, if there's acute trauma, if there's elevated cardiac troponin. Okay, so all of these 7 things are the indications for admission. Okay, so if the patient doesn't have any of that, you just manage him. You give him non-steroidal anti-inflammatory drug and colchicine for idiopathic or viral pericarditis. Okay, and the patient should be continued on non-steroidal as long as he's symptomatic, usually less than 2 weeks. Okay, and you treat with colchicine for 3 months. Okay, it's very interesting. But if there is a patient who had an MI 2 weeks ago and had pericarditis, you avoid non-steroidal anti-inflammatory drug other than aspirin. Okay, so just watch out for that. And if the patient have viral pericarditis or idiopathic that resistant to non-steroidal and colchicine, like after 2 weeks didn't improve, then you do steroid. Okay, steroid you given also if the patient had autoimmune pericarditis. Okay, this one thing. Other thing, you treat the underlying if the patient have pericarditis due to renal failure, hemodialysis. Okay, so usually non-steroidal and colchicine. If that didn't work, then steroid. If that didn't work, you just treat the underlying, like if it's because of renal failure. Okay, so that's basically it. Let's walk you through a case, very simple. So as we said, always the mnemonic is going to save your life. It's very important. First, you do the police BS, pulse ox, cardiac monitor, IVXS, BP monitor, EKG. After that, you advance the clock. You get the EKG, diffuse ST elevation. Oh, you get your diagnosis. After that, you do the cut gleam, CBC, BMP, chest X-ray, cardiac enzyme, ESR, blood culture to see the source of infection if there is an infection, and you give ibuprofen and colchicine. And that's basically it. After that, you admit to the ward, you ambulate at well, echocardiogram, reassured, and you cancel oxygen. You don't need it in this case. It's not a pneumonia or respiratory distress. And you just advance the clock. You get the echocardiogram results because you ordered echo after you saw the diffuse ST elevation, because you want to see if there's a large effusion. You do pericardiosynthesis, and you can cancel cardiology too. Okay, if there's pericardial effusion but no tamponade, then that's it. You cancel the cardiac monitor, BP monitor, IV access, and you evaluate the patient daily, every day. Just advance the clock, Q day in the system until the patient improves. Once the patient improves, that's it. You did a great job. You cancel the vitals, order patient counseling, and you send the patient home. And you just schedule appointment in 2 weeks. And that's it. Usually the case ends at this time. Okay. There's one thing important, the chest X-ray before echocardiogram is very important. Okay, and the other thing is that we gotta do cardiac monitor. It's very important. You shouldn't forget these things, these 2 things, very important. Okay, so basically simple. You do the police BS, and once you see ST elevation, you do the cut gleam to start him ibuprofen and colchicine, and that's it. You just follow up. After that, you order the echocardiogram, the 3rd step. So 3 steps: police BS, cut gleam, ibuprofen, colchicine, and then echocardiogram. And you reevaluate every day, and usually ends. After that, you cancel, and that's it. The case ends. So the management for pericarditis is very simple. Initially, steroid, colchicine. Didn't work, then you add steroid. That's it. If there is an underlying renal failure, you manage the underlying. And that's the acute pericarditis. Simple and easy. Thank you so much for listening, and I will see you in the next one.